Welcome back to Midnight Med. This video is on diverticular disease. Diverticular disease is most often asymptomatic, but some patients may present with altered bowel habit like bleeding, or potentially abdominal pain and cramping. It may present acutely with diverticulitis, that is, inflammation of the diverticula, in which case we might see fever, nausea and vomiting, rigidity, guarding, and crampy abdominal pain and tenderness, particularly in the lower left quadrant. In those of Asian ethnicity, this might present on the right-hand side. Diverticulitis can also be complicated by abscesses, bowel obstruction, or perforation. The pathophysiology of diverticular disease centers on the formation of diverticula, which are small outpouchings in the bowel wall. This occurs more commonly in the large bowel than in the small bowel. The causes are unclear and are likely to be multifactorial. Some theories include increased colonic intraluminal pressure, low fiber diets, altered microbiota, and genetics. When these diverticula are inflamed, we get diverticulitis, as we mentioned a little bit earlier. The schematic on the right-hand side illustrates the difference between the development of diverticula and the development of diverticulitis. The reason why diverticulitis occurs is unclear, but it is thought that obstruction by fecaliths leads to trauma and inflammation before causing microperforations in the bowel wall and bacterial overgrowth. This can lead to abscesses forming, as well as fistulation and obstruction. Key risk factors include age, smoking, obesity, a diet that's low in fiber and high in fat and red meat, and certain medications such as NSAIDs, steroids, and opiates. There is also a potential genetic component to the development of diverticula and consequent diverticulitis. The key investigations include imaging with a CT of the abdomen and pelvis, using both oral and IV contrast. In acute diverticulitis, we should see fat stranding, bowel wall thickening, and small abscesses in the wall. Abdominal ultrasound may also be helpful. Blood tests include an FBC, a full blood count, CRP, ESR, and blood cultures where acute diverticulitis is suspected. A colonoscopy should be avoided in acute diverticulitis because of the risk of bowel perforation. The management depends on whether the patient presents with asymptomatic, non-acute diverticular disease or whether they present acutely with diverticulitis. If the patient is asymptomatic, the aim is to reduce intestinal pressure and spasms using diet and fluid intake. It's important to remember that most bleeding is self-resolving. If there is persistent bleeding, then embolization, cautery, or coagulation may be useful to manage this. Surgery can be considered in the case of very large diverticula and can be used to reduce them given the risk of infection and rupture. In acute diverticulitis, supportive therapy with IV fluids, IV antibiotics, and pain relief are the priorities. Additionally, abscesses should be drained, and surgical correction of fistulae and perforation are indicated. In the case of bowel perforation, a surgical resection of a segment of bowel is performed. In those with acute diverticulitis, a colonoscopy is performed 6 weeks post-recovery to screen for colorectal cancer. So that's it. Thank you for watching. Don't forget to like, subscribe, follow us on Instagram for more, and we'll see you in the next video.